This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Neurologia medico-chirurgica, published in 2026, titled High Parietal Endoscopic Approach for Thalamic Hemorrhage, Technical Nuances and Preliminary Outcomes.
This is a topic close to my heart, Alara. Thalamic hemorrhages are notoriously difficult because of their deep location and frequent intraventricular extension, what we call IVH. For decades, our standard was often just an external ventricular drain, or EVD, and hoping for the best with medical management. But this paper looks at a much more proactive, minimally invasive surgical philosophy.
Exactly. The study is a retrospective review of 270 patients treated between April 2006 and July 2024. It's interesting to see the evolution of their practice. Prior to 2017, their primary treatment was indeed EVD. If there was a thick intraventricular hematoma, they'd use an anterior endoscopic approach primarily just for the IVH removal.
Right, but the shift occurred in April 2017. That's when they started using the high parietal approach. What makes this specific technique the focal point of the paper?
The hallmark of the high parietal approach is that it allows for the simultaneous removal of both the thalamic hematoma and the intraventricular hemorrhage. In this study, they applied this to 21 patients.
Simultaneous removal is key. If you only drain the ventricles, the deep thalamic clot remains, exerting mass effect and secondary injury. By going in through a high parietal route, you're navigating a trajectory that can often address both compartments. Let's talk numbers. How effective was the evacuation?
It was quite impressive. The high parietal approach group showed a median hematoma evacuation rate of 92.2%. For a deep-seated thalamic bleed, getting over 90% out endoscopically is a significant technical achievement.
It certainly is. But as we tell the residents, it's not just about how the CT looks, it's about the clinical trajectory. How did these patients fare compared to the old EVD-only group?
The data showed several significant advantages. The high parietal group had a significantly shorter duration of ventricular drainage. They also had a lower incidence of tracheostomy, which suggests a faster recovery of consciousness or respiratory drive.
That's a major point for our residents to note. Shorter drainage time usually translates to lower infection risks. Did they see many complications?
Remarkably, there were no cases of surgical site infection or meningitis in the high parietal approach group. However, it wasn't without risk. They reported 2 deaths in that group, one due to postoperative rebleeding and another due to worsening pneumonia and heart failure.
Rebleeding is always the specter hanging over endoscopic evacuation. We have to be meticulous with hemostasis in that small working space. What about long-term CSF issues? Hydrocephalus is the bane of these IVH cases.
That's where the high parietal approach really stood out. Secondary hydrocephalus requiring a permanent shunt placement was observed only in the EVD group. Not a single patient in the high parietal group required a shunt.
That is a striking finding. By clearing the thick blood from the ventricles and the source of the bleed in the thalamus early on, you're likely preserving the arachnoid granulations and preventing the fibrotic changes that lead to shunt dependency.
I also noticed an interesting clinical detail. Though it wasn't statistically significant, the high parietal group showed a higher rate of early resumption of oral intake. It suggests these patients are waking up and neurologically improving faster than those left with an EVD and a large clot.
So, to summarize for our listeners, we're looking at a shift from passive drainage to active, minimally invasive evacuation. The high parietal approach offers a median 92.2% evacuation rate, less time on a ventilator, indicated by the lower tracheostomy rate, and potentially eliminates the need for permanent shunting.
Precisely. The authors conclude that it's a minimally invasive technique that facilitates early postoperative recovery and reduces those classic complications like prolonged drainage and hydrocephalus in selected patients with large thalamic hemorrhages.
It's a compelling argument for the high parietal route. Technical nuances matter. The trajectory allows that dual compartment clearance that an anterior approach might miss. Alara, thanks for breaking down the data.
My pleasure, Dr. Aris.
And thank you all for listening to the Neurosurgery Hub podcast. Stay tuned for our next episode where we dive into more technical nuances of the skull base. Until next time.